Hello, everyone. All right, so I hope everyone can hear me well today. I just a few minutes before going live, I realized that the plug-in for my microphone had broken. So if you hear a lot of feedback or you're not able to hear me well, please let me know and I'll try to amplify my voice. I apologize for that. I'll make sure that I have a new microphone for the next live. So, as usual, I'll go ahead and give a few minutes for a few more people to join on so that we can go ahead and get our conversation started today. All right. I hope everyone's having a wonderful Saturday as usual. I'm excited because I get a few days off of work next week, so I'm really excited about that. All right. Our topic today is on the PAP smear. This is a screen that is a very common screen for a lot of people, but not everybody. So, and I realize that even for the people that do come in for their routine PAP screens, not everybody's really sure of what they're doing or why they're doing it. So, I figured we would go ahead and delve a little deeper into what the PAP is, why we do it, and what exactly it is we're looking for. And maybe just touch briefly on some things that we do to follow up on the PAP. I see we have a few people starting to join in. Hi, Dr. Jeffries. How are you? Thank you for joining. All right. It's almost 11:30, almost our start time, and I'm trying to stay consistent with starting right on time. So maybe I'll give another minute and then go ahead and get started. Okay. And I thank everyone for their feedback on from the last couple of lives on sending me questions, sending me ideas for things that you want to hear about. That's how I get my ideas for these topics. Partly through what you send me and also partly through some of the questions that I answer routinely in the office that folks seem to want to know more about. So thank you for that. If you're joining in now, go ahead and type in a hi or a hello or a wave or something so that I know that you're here. If you are watching this on replay, if you could type in hashtag replay. I like to go through and just make sure that I acknowledge everybody that joins us on these conversations. So, okay. All right, well, I think I'll go ahead and get started now. So again, today we are doing a GYN topic, and I chose hi Kwame, I see you. I chose the PAP smear as our topic for this week. So the PAP smear is a screening test that is recommended for women to undergo. Hi, Priscilla. It's gone through a couple of different changes over the years as to what we recommended people needed to do. So a couple of years ago, at least here in the United States, the recommendations were for all females at age 18 or above, or all females from the minute they were sexually active. I mean, well, not minute exactly, but from the first time they were sexually active to start undergoing screens. The organization that governs what we do with regards to screening tests for cervical cancer is called the American Society for Colposcopy and Cervical Pathology, ASCCP. It's gone through a couple of revisions over the years. The most recent revision was in 2012 and came up with some criteria. Now, there's several other organizations that also have their recommendations, but for the most part, the consensus now is no women at age 21, regardless of whether they've been sexually active before, should start getting their screening test. I was interested to find out that in doing a little bit of research, because I promised you guys that I would, look up information for, England and Africa, since a lot of you are joining me from different places. And it appears, and correct me if I'm wrong, but from what I was looking at, it looks like in England, the recommendation is for age 25 for a screening test. And I couldn't find a consensus for most places in Africa. But in the United States, the recommendation is age 21 and above. Women need to get their screening tests for cervical cancer. Now, our method of doing the screen is through the PAP test. Hi everyone. Hi Akos. Hi Dr. Knight. Thanks for joining. So our method of choice for doing this is the PAP smear. The recommendation in the United States and in England is for the PAP to start at age 21 in the US, 25 in UK, and all the way through age 30. The screen is every 3 years. From age 30 and above, there's a little nuance to how we do the screen. Now I'll backtrack a little bit and go a little more into why we're even doing the screen. So as I alluded to a little bit, what we're screening for is risk for cervical cancer. It's not a cancer screen. It's really for the risks so that we can help with prevention of progression to cervical cancer. Most of the causes of cervical cancer are through exposure to a virus called HPV, human papilloma virus. We can get exposed to HPV through any kind of sexual contact, so sexual fluids. Now this includes oral transmission of fluids, genital transmission of fluids, oral to genital, so kissing, intercourse, which means that it spans the whole general. You don't have to have penetrable intercourse to get exposed to HPV. The family of HPV viruses is a broad spectrum of viruses. There's a lot of different viruses in the panel. Some cause things like warts, so little, almost like skin tag-like lesions, which I don't want to say they're not concerning, but in the grand scheme of things, in terms of cancer risk, they don't typically progress to cancer. So you could be exposed to an HPV virus that does not cause cervical cancer, but it causes maybe genital warts. These are some of the lower risk HPV ones. There are others that don't even do anything. The ones that we're specifically looking for, and by we, I'm talking about your family doctors, your OBGYNs, your the folks that will screen for, in some places, midwives, and nurse practitioners, the folks that will screen for cervical cancer. What we're looking for is mostly exposure to some of the higher risk types. Almost worldwide, there are 2 types of HPV that tend to cause most of the cervical cancers, type 16 and type 18. To a lesser degree, 45 as well, but 16 and 18 cause about 70% of all cervical cancer. And I like to always throw out the statistics for you as well. It looks like, hi mommy, it looks like there's probably just a bit over 500,000 cases of cervical cancer worldwide annually. 35 out of 40 of the countries that had high cervical cancer numbers were in Africa. So 35 out of the 40 high impact countries were in Africa, which is a little concerning. India alone accounted for about 1/5 of the worldwide population of exposure to new onset cervical cancer. So that's another thing that's concerning. Hi, Fischel. Get the girls. Okay, so, and then out of the 500,000 cases that are diagnosed annually, so that doesn't necessarily mean that that's all that happens. It means that that's what's diagnosed from the people that are actually going in for their screens. Out of that over 500,000, about 300,000 deaths annually are from cervical cancer. And as I go further to actually describe what the test entails, it's such easy screen to do, and some of the management you have time to get the girls, some of the management things that we can do to treat it are basically there shouldn't be any reason why we have so many people dying from cervical cancer, because the options available are quite simple. I don't want to simplify it too much, but in the grand scheme of things. Okay, so let's see. we've talked about the PAP test as a screen for exposure to HPV, which could cause cervical cancer. We can get the exposure to cervical cancer through any kind of sexual interaction, either orally, genitally, oral to genital. So this, and there's several strains of the HPV virus. So this obviously means that cervical cancer is not the only thing that could result from exposure to HPV. You can get cancer of the vulva, which are the lips of the vagina. You can get cancer of the vagina itself. You could get cancer of the mouth, cancer of the throat, cancer of the penis, cancer of the anus. So when you go for your routine screens, when your physician, either your obstetrician, your primary care doctor, if they're doing a genital exam, they're not just looking at the cervix. We're looking at the labia, we're looking at the vagina, we're looking at the anogenital area. So that's the area between the anus and the vagina for me, penis for other doctors. I don't do that. Okay. And then of course, if you have any oral lesions or anything like that, your dentist and whatnot can probably screen for those. Okay, so the other statistic that is unfortunate to me is it seems like majority of the people that do end up having cervical cancer do tend to be more of the melanated folks. So blacks higher than whites tend to have cervical cancer statistically. There was a survey done a few years ago that said that at least in the United States, 1 out of every 20 women between the ages of 30 to 65 had never had a pap smear. A lot of the issues in some parts of the world tends to be access to care. When it comes to the pap smear, yes, there are places in the United States where access to care is still a big issue. But in a country as well developed as this, that's something that I find to be very unfortunate, that so many women are going without having their pap smears done. Now, sometimes it's not just access to care. Sometimes it's because, as the bedrocks of our families, women tend to focus more on taking care of everybody else in the family and putting their health on the back burner. I was remiss because I did not reintroduce myself and what my mission is at the beginning of this like I usually do. My mission as Dr. Banger, your board certified OBGYN, is to demystify some myths regarding the female body to help empower you to make decisions that will impact your lives, the lives of the females in your lives, and your daughters. So my plea to you is, remember as women, for the men that are on the show, remember for the women in your lives, that we have to take care of ourselves to be able to continue taking care of our families. Even though we're giving so much to them, if we're not in good physical health, if we're not taking care of ourselves, then we're really doing our families a disservice. So get your pap smears. Okay. All right. I'll get down my soapbox now. Okay. So yes, a lot of women would get their pap smears maybe when they're pregnant, because when you go in as a pregnant woman, typically you will get a pap smear if you haven't had one based on the guidelines, which I'll go into later. But other than that, a lot of people that I have seen personally who have cervical cancer, the last time they had a screen was when they were pregnant, and it could be 5, 10, 15 years ago, and they never went back to see their gynecologist or to see a physician who does a pap smear. And then they end up back with symptoms that turned out to be cervical cancer. Cervical cancer is one of the female cancers that is not genetic. So using the excuse that nobody in my family has cervical cancer is not really valid. It's different from breast cancer. It's different from uterine cancer. It's different from ovarian cancer. Cervical cancer, we're at risk for cervical cancer through our individual exposure to the HPV virus. Again, HPV virus, 70% of the cases. Okay. So let's talk a little bit about the pap smear itself, the meat of what we're doing. When you go in for a pap smear, I've had folks that come in very uncomfortable with, I'm so sorry with what you see down there. don't be self-conscious about what the vagina looks like. Our job is to look at that. There are so many different ways the vagina looks. So that seems to be a area that some women are very uncomfortable with. I'm sorry I didn't shave. I'm sorry, should I have shaved? We can get to it. Unless there's, I've never ever not been able to get to the vagina. So do you. If you like to shave, that's fine. If you don't like to shave, that's fine. Don't apologize for it. When you come in for your pap smear, right now with COVID, we're not allowing too many people back into the exam room with us. But hopefully we go back to normal. And if you have a support person that you want to bring with you, that's fine. They can hold your hand through it. At least in my office, we always try to make it a very comfortable, warm environment so that you're not too stressed through this procedure. But you will be placed on your back with your feet in stirrups. And a small device, a speculum, will be inserted into the vagina. When we first insert it, obviously something's going to the vagina, so there might be a little bit of discomfort with it. Best thing to do, deep breaths. Just deep breaths in and out. Relax all the muscles down there, because if you tense up and you tighten, that makes it a little more uncomfortable as something is penetrating in and you're tightening. So it's almost a little more uncomfortable that way. So just relax. As the speculum goes in, we do have to open it up a little bit so we can see the cervix. So there's 2 periods that I usually will warn patients about. Okay, speculum is going in. You might feel a little bit of pressure. All right, and then I always remind folks to take a deep breath in as I open it up a little bit. It shouldn't cause excruciating pain. If your physician is being a little too aggressive about putting it in, don't hesitate to say, ooh, could you go a little more gentle, okay? Doesn't have to be shoved in. So once we can see your cervix, we will use either a spatula or a brush or something with soft bristles on it to take a sample of cells from the cervix. And that's it. That's your pap smear. We use, I use the spatula and a brush. So when that's happening, yeah, it might make your toes tingle a little bit, but it's not severe pain that should preclude you from wanting to do your pap smear. So once we do that, that's it. It takes probably 5 minutes at best to get you in position, to put your feet up, and to do the procedure. And that's it. We send it off to a pathologist to look at. There are several results that can come out of a PAP. Sometimes it can come back showing absolutely normal cells. No abnormalities on the cervix, no exposure to HPV. Now let me go a little bit into how we actually screen in terms of age. So we screen based on age. From age 21 to 29 here in the US, and like I said, for the UK, it appears to be from age 25 to 30. We typically recommend a pap smear every 3 years. The group of people between 21 and 24 who have just recently become sexually active, especially if they're not with one particular partner, sometimes I'll do a PAP every year from 21 to 24. The guidelines do say every 3 years, but if you're at higher risk for exposure, sometimes we need to tweak that a little bit. So yes, we do the screen every 3 years up until age 30. And it's a 5-minute test every 3 years. It's really not that bad. If the cells come back negative, because usually from that age group, we don't specifically screen for HPV, we screen for abnormality on the cervix. If it comes back and there's nothing abnormal on there, that's fine. You're good. You can still do we still recommend your annual screens every year, but the PAP component of it can be spaced out to every 3 years. Some people correlate their yearly exam with a pap smear, thinking that every year you come in for your yearly, you need to have a PAP. That's not true. The PAP is a component of a yearly exam, and it does not have to be done every single year. From age 30 to 65, if you have normal PAPs, we usually screen every 3 years or every 5 years. Now, we do change the way we screen from age 30 to 65 a little bit. If we do just a sample of the cells from the cervix, which usually goes in a liquid-based formula. We take the sample, we put in a little liquid, we send it off to the pathologist, and that comes back negative, then yes, you're good for every 3 years. But there's also criteria for screening specifically for HPV from age 30 to age 65. And I think, oh, that's the other thing. Put your questions in the comments. I see there's a question right here. And yes, I do plan on addressing that. So at the end of the lecture, I'll go back and go through all the questions and I'll address all of them. For those of you still joining in, please type in a hi, a hello, just so that I can acknowledge you're here. If you're watching this on replay, type #replay so that I can acknowledge you're here. So yes, from age 30 to 65, a PAP smear every 3 years if we're doing just cytology, meaning just the liquid sample with the cells in it, or if we do the HPV screening with it and you're negative for both abnormal cells, so your cytology is negative and your HPV screen is negative, you actually can space out your PAPs every 5 years. So every 5 years, 5-minute screen, very simple. Okay. Hi. Thank you for joining. Thank you. All right. So if we find that we have cells that are not normal, they can be classified into two different broad groups. They can either be lower risk abnormalities that we see on the cervix, or they could be higher risk abnormalities. And for the basis of simplicity, I'll just leave it at that. I could go into like the nuanced different little categories, but that might be a little too much. So I'll just put them in two broad categories. If we see just mild changes in the cervix from age 21 to 24, age 21 to 30, or from 30 to 65, depending on exactly what we see, we may say something as simple as, you know what, we may just need to keep a closer eye on this. Come back next year. Let's repeat your PAP. When you come for your annual next year, we'll repeat your PAP again, just to keep an eye on it. Other times, we might see some changes that have us want to go a little deeper. So in that case, we might recommend a procedure called a colposcopy. When we do a PAP, again, is a screening test. With screening tests, it means that we look at a broad category of people. We send it all to the pathologist. They do a cursory look at it to make sure that there are no gross abnormalities there. Because of that, there could be, sometimes if they see the minor little changes, they might say, take a closer look at this. So there could be false positives in there. There could be times that we call and say, you know, we want to take a closer look at your cervix because there were some changes there. And we actually do this closer look and it comes back negative. So just because you get a call back after a PAP saying you need to come back for a further procedure doesn't mean that you have cancer. I get people very upset and teary sometimes over the phone if we say that, and we spend time to explain that to you before, but for some reason not everybody processes that. So hi Ruby. Okay, hi Emma. So remember, and we might need to continue saying this to folks to remember, but I'm going to tell you again here. Just because you get a call back after a PAP does not mean you have cervical cancer. It just means that there's some areas that we just might want to take a closer look at, or we just want to confirm what we really think we saw. So a diagnostic screen, so first we've done a screen. It's come back with maybe some areas we need to look at. So we want to do another test, which would be more diagnostic. So a diagnostic screen that most of us will go to first is something called a colposcopy. A colposcopy, I like to describe as a PAP times 2. So basically, we're looking at the cervix again, and we're this time looking at it not just with our naked eye, but we're looking at it under a microscope. So the setup for a colposcopy is the same as for a PAP. You're on your back, your legs in stirrups. We put the speculum in to look at the cervix. The difference here is we will typically apply a little solution to the cervix. And there's two main solutions that we typically use. There's one called acetic acid, which is like vinegar, that will spray on the cervix. Or there's another one called Lugol's, which is a brownish liquid that we put up there. The thought is areas of the cervix, the cells on the cervix, the squamous cells of the cervix that are growing a little more rapidly or a little differently from other areas will absorb either the acetic acid or the glucose a little differently. So then we can better delineate areas that are concerning on the cervix, and we look at the cervix under the microscope, the colposcope, and we put a green filter because we're able to better see the areas that may need more evaluation. So sometimes we'll do this and we'll say, you know what, it all looks fine to us. You don't need to have anything else done. We'll just follow you in a year. Other times we look, and if there are any areas that make us just go, let's look at that a little further, we will recommend doing a biopsy, meaning we take a little pincher device and we just pinch a tiny little bit of the cervix. It sounds painful, but actually a lot of people don't even feel it sometimes if we do it sneakily. Usually I'll have folks give a cough when I'm doing it, and they're like, what did you do? And that's it, it's over. So take a little pinch of the cervix, of the area of concern. And we will also sometimes do something called an endocervical curettage, meaning we take a brush and we go inside the cervix a little further deeper, the area we can't see too well, to get a sample of the cells from there. Depending on what your PAP came back as, every now and then, this is a rare finding, but every now and then we also need to get a sample of cells from further inside the uterus. So not just an endocervical curettage, but an endometrial, so inside the uterus. So we do a biopsy from inside the uterus, because sometimes we'll see some glandular cells, which should not be on the cervix. We'll see some glandular cells on the cervix, and we want to make sure that there's no endometrial cancer going on. So even though our focus is on cervical cancer, primarily when we're doing your PAP test, there are a lot of other areas that we're still being vigilant about. So if we see any endometrial cells on the cervix, sometimes that's an indication for us to go ahead and do a biopsy of the endometrium as well. So PAP smear. You're on your back, legs in stirrups. We put a speculum in, a little bit of pressure. We open up the cervix, a little bit of pressure there. We take a sample of the cells, usually with a brush or a spatula or both, and that's it. Colposcopy, similar. Difference is we do apply some solution to the cervix first, either Lugol's or acetic acid, and we look under the colposcope with a green filter, and we may either do nothing or we may take a biopsy, and we may also take an endocervical sample or an endometrial sample. So sample of cells from the cervix or sample of cells from the uterus, and maybe a tissue sample from the cervix. We send that off to be looked at. That's the colposcopy is both a diagnostic and also a screen, a possibly therapeutic screen. That means that when we take those samples, it gives us a more definite diagnosis. So diagnostic screen. If we take a biopsy of an area of cells that we were wanting to investigate further, and that's enough to just, and those turn out to be abnormal cells, but that's enough to just take those abnormal cells off, that could be your therapy. That could be the treatment. That could have just fixed the problem. So it can be both diagnostic or therapeutic. Both diagnostic and therapeutic. So colposcopy, another easy procedure. You don't need anesthesia for it. You don't, it's completed in about 5-10 minutes as well. So you're in and out of the office to have that done. Although I thought I saw in the UK that most colposcopes might not be done in the office. Correct me if I'm wrong. Those of you that are there, correct me if I'm wrong. Okay. Okay, so for those of you who joined later, I'll do just a brief recap. All right, PAP screen. We're screening for abnormal cells on the cervix that could eventually cause cervical cancer. It's a preventative screen because if we find something, we want to try and treat it before it gets to the point of cervical cancer. Cervical cancer is not genetic. It's different from breast cancer, uterine cancer, ovarian cancer because we don't get the gene for cervical cancer through family transmission. We get it through our individual exposure to usually the HPV virus, which is we're usually exposed to through sexual intercourse. And by that, I mean oral intercourse, oral to genital, genital to genital. HPV the different strains of it, 16 and 18, are the highest risk for cervical cancer. They're responsible for 70% of cases worldwide, over 500,000 cases of cervical cancer worldwide, about 300,000 deaths from it. A lot of the countries that are high risk for cervical cancer are in Africa. India is another high risk area, and generally blacks are more common than Caucasians to have cervical cancer, either because of access to care or us sacrificially taking care of our families and not taking care of ourselves. So I charge all the men on here. If your wives are not going, if your sisters are not going, if your daughters are not going, it's your job to make sure that they go. And it's our jobs as women to make sure that the other women in our lives are going to get this done. Because as we can see, it's a pretty simple test to get done. Okay. All right. So is there anything we can do to make sure we don't get exposed to HPV other than total abstinence, which is not realistic? I mean, except for nuns, or yeah. Okay, I will delve into that. But yes, there are, of course, making sure that we're, not having too many sexual partners, making sure that we use condoms for intercourse. But there is a vaccine for the HPV virus, and this is something relatively new. I believe, and I may get the year wrong, but I think I was still in medical school when the vaccine came out. So that would have been sometime between 2009 and 2011. Did I just age myself? Okay. But the vaccine has gone through a series of tests, at least here in the United States, over the years. And currently, there are two options for getting the vaccine. There's a 2-dose option and there's a 3-dose option. And it started out that it was for females starting age 11 to 26. Now, over the years, it's been screened in lower ages and in more advanced ages. And the vaccine can actually be given to boys as well. So from ages as early as 9, you can give the HPV vaccine. If you do the 2-dose vaccine, that's usually recommended for our teenagers who are getting it younger, or our children who are getting it younger than age 15. It's a 2-dose regimen. You get the first dose, and usually sometime between 6 to 12 months later, you get the second dose. If you're getting the vaccine older than age 15, then it's usually recommended you get the 3-dose. And you get the first dose. 1 to 2 months later, you get the second dose. And then about 6 months later, you get the third dose. It's still more commonly recommended for up until age 26. However, some people between age 26 and 45 can get the vaccine as well. You want to talk to your doctor about this, because if you've already been exposed to any of the high risk strains already by age 26, then the vaccine really just protects you if you've never been exposed. So if you've already been exposed, then it might not necessarily be ideal for you. The main thing about the vaccine is if you've not been exposed, then it can protect you against those high risk strains. Remember, there's a lot of different strains of HPV, but it's mostly those high risk strains that we're worried about, 16, 18, and to a lesser degree 45. My thoughts about the vaccine, given the prevalence of cervical cancer, I think it's a good thing. I would vaccinate my children against the HPV virus. That's my personal opinion. This is something that everybody can make a decision about. You don't have to do it if you don't believe in it. But just at least knowing that it's available and out there is part of the empowerment, right? Because we're empowering here. Okay. So I'm cheating because I saw a question earlier about that. I'm going to address your question, even though I like to address it at the end. But yes, in the UK, you said they are offering it as early as age 13 to children. That does fall within the criteria for the vaccines recommendations as well. Okay, and it's not an okay to our children to say just because you got the vaccination you can go out and have sex and have nothing happen. There's a lot of other things that go along with sex, so this is just a preventative option available. Okay, let's see. The vaccine, are there any adverse reactions to it? Nothing severe. Now, I will say that folks that have a latex allergy or a yeast allergy should not get the vaccination because there have been some anaphylactic reactions to that. If you have a latex allergy where you have shortness of breath, you can't breathe because your throat swells up, you should not get the vaccination. Same with yeast. That's pretty rare. More commonly, people will have maybe some pain at the site of the injection, some redness, a little tender, just like with any injection. Every now and then you could get a low grade temp with it, so 99, 100, something like that. And very rarely some people will get maybe some nausea. It's not been my experience. I can't recall over the last 2 years having anyone that even had those other than the pain at the site. So it's not very common that you would get adverse reactions to it. But again, if you have a yeast or a latex allergy, you should not get the vaccination. Okay. Let me go ahead and take some questions. Let me do that. Let me look through. If you are on here, please, please, please put in a hi, put in a hello, wave at me. Hello, hello, hello. If you're watching this on replay, hashtag replay. Type that in for me, okay? All right. Hi, Winna. Hi, Carolyn. Okay, hi, Sharon. Hi, Michelle. Hi, Abby. Okay, Abby, I hope that answered your question. I don't see a whole lot of questions. Yeah, please put your questions in here if you have them. And even if you think of them after watching this live, you can still type them in. I come back periodically and look at everything so that I can make sure everything's addressed. So I think I talked a little bit about doing the colposcopy. I'll touch briefly on some other things that we might do if the colposcopy results also come back abnormal. So you've had your PAP, it came back with some abnormal cells. You've had a colposcopy to be a more diagnostic screen, and we've maybe had a biopsy. Oh, thank you, Mommy. You've had a biopsy, you've had further samples sent off. They come back and they say, you know what, this was all normal. That PAP was a little, too ambitious. Nothing else needs to be done. Just follow here in another year, basically, would be the implication from that. Okay, I see more questions. I'll get to them. Or sometimes it comes back and it says, yes, what we're finding is very similar to what the PAP showed. It's the same. Typically, in that instance, we'll also do a PAP in a year. Every now and then, we'll get the results come back and they say that the cells are actually higher grade than what the PAP showed. In this case, depending on exactly how high grade it came back, if it's starting to get close to cervical cancer or what we call cancer in situ, cancer that is contained, or cervical cancer, we might recommend, and usually cervical, let me just leave it at cervical cancer in situ, because if it's cancer, then we sometimes have to refer you to an oncologist, a GYN oncologist, for more extensive treatment. But if it's in situ or higher grade than what the PAP showed, we may recommend some other procedures. You can get a procedure where we take a bigger sample, a bigger bite of the cervix off, so that we can just kind of carve out all those areas that have abnormal cells out. Your cervix is 3 to 4 centimeters long in most people. So when I talk about doing the biopsy, we're literally just taking tiny little pinches when we do the biopsy. It's not going to shorten your cervix. So having a colposcopy with a biopsy should not increase your risk for preterm labor if you were to get pregnant later on. anything like that. Now, some of these other procedures that we could do if you have higher risk cells could eventually over time maybe affect that. One of the procedures that we might recommend is something called a loop electrocautery excision procedure. That means that we take a device, and let me use my pen, and it's got a little wire tip to it, a wire loop on the end of it, and we heat it up, and so that's the electrocautery aspect of it, and we take out the superficial top layer of the cervix off. Again, 3 to 4 centimeters long for the cervix. We're talking about taking a tiny little sliver, maybe 0.5 of a millimeter sliver off. That could usually contain all the abnormal cells. So that might be a more therapeutic option that we recommend that you have done, a LEAP procedure. Other times we may recommend freezing that area, so something called cryotherapy, where we apply a device that will freeze up that area and then we carve that out. Sometimes we will do a laser ablative procedure, so we burn out that area. Or the one that's probably a little more extensive is a conization. So we use basically a scalpel, a knife, and this is your cervix. We basically cone out an area. So we're not just taking a thin sliver, we're taking a sliver that goes a little deeper into a cone so that if there's any abnormal cells behind it, that also wedges it out. So if you have one cone procedure, you can still have full-term, pregnancies. If you've had to have repeated cone procedures, you can see how that could gradually over time shorten the cervix. And if you don't have a nice, strong cervix, then sometimes that could cause some preterm labor precautions there. So, okay. Let's see, talked about the conization, talked about all of that. Oh, so we talked about screening from age 21 to 29 being every 3 years, and then from 30 to 65 being either every 3 years or every 5 years. So what happens after age 65? Well, from the studies that have been done, and the risk of cervical cancer, new exposure over age 65 is incredibly low. So currently the guidelines state, at least here in the United States, that after age 65 you don't need to have pap smears anymore, especially if your last 2 to 3 paps were normal, and then you're pretty low risk for it. If you have new sexual partners or whatnot, these are screening guidelines. These are not commandments handed to us from, the Bible or, the Quran or, whatever your deity is. But so they're screening guidelines. So you can definitely have a conversation with your physician about whether you are in a risk category group that should have screening past 65 or not. But for most average risk people at age 65, you no longer need to have a pap smear. If you have had a hysterectomy and your hysterectomy was not because of cancer of any sort, especially not because of cervical cancer, and you had not had abnormal paps of the high risk category prior to your hysterectomy, you don't need paps anymore. So if you are 40, you've had a hysterectomy at age 40, it was because of fibroids or bleeding, but it wasn't because of anything cancer related. You were done having children or didn't want to have children anyway, and you just take that thing out. And it was taken out for that reason. You don't need to have PAPs anymore if your cervix was taken along with it. So if you had a hysterectomy for benign reasons, meaning non-cancer reasons, and you had normal PAPs leading up to that hysterectomy, and your cervix was taken out along with your hysterectomy, because a hysterectomy just means we take out your uterus, but it can be with or without your cervix. So either super cervical or total, that's a discussion for another day. But if you had your cervix taken out as well, then you don't need to have PAPs anymore. If it was for cancer reasons, especially cervical cancer reasons, then you need to have PAPs for up to 20 years past when you had that hysterectomy done. So if you had cervical cancer and you had a hysterectomy, and you are 35, you still need to have PAPs for at least 20 years. If you are 55, you need to have PAPs for at least 20 years past that. Hope that makes sense. Let's see. I see a few more questions here. Can HPV contribute to getting ovarian cancer? Technically, no. Now, you can have cervical cancer that travels up. So the primary focus is a cervical cancer, and it travels up. Usually cervical cancer travels up a little differently than some of the other cancers, but cancer can spread to surrounding organs. So you can get cervical cancer and actually have some uterine involvement, have some other GYN organ involvement of it. Usually it's the lymph nodes. Sometimes it can even be the vagina being affected by it. But ovarian cancer per se is not caused by cervical cancer. So those are two completely separate things. Okay. All right. And I thought I saw one more question here. Can HPV? I was about to ask that. What if you have an active sex life after 65? If you have an active sex life with recurrent partners, if I was your OBGYN, I would still do pap smears for you after that. Life doesn't end at 65. I don't know why that cutoff has been. It probably is because we need more data. But as of right now, 65 is the cutoff. But again, it's just a guideline. There are exceptions that can be made. Another group that sometimes might need exceptions made to all these criteria we've gone through, any people that are in groups that are immunocompromised. So immune systems that are not working quite as well as they should. The group that comes to mind off the top of my head would be anybody that's HIV positive. We may not want to wait 5 years for PAPs on people in this category, or even 3 years. We might need to do it a little more frequently. In pregnancy, let's say you came in, you were pregnant, and from my last live, I know I had a lot of people on there that were not thinking of childbearing, but you know people that are. So if you know anyone that has had a PAP during their pregnancy and it came back abnormal, most of us would still recommend a colposcopy at least to get a closer look to see what we're dealing with. Because of how much blood flow there is to the uterus and the cervix in pregnancy, we may be a little more reserved when it comes to doing a biopsy in pregnancy. We might just want to watch it real closely just to make sure it's not progressing, but not necessarily do a biopsy because you can have a lot of bleeding. But sometimes we'll see some lesions that we just have to know because it could progress and get worse during the pregnancy. So if we have to do a biopsy on a colposcopy when you're pregnant, just know that there could be a lot of bleeding, and most of us will only do that if it's absolutely necessary. All right. I think that's what I wanted to go through with you over PAPs. I wanted to go over why we do PAPs. We do it to screen for exposure to HPV, which could cause cervical cancer. HPV can cause a lot of other things. It can cause genital warts. It can cause vaginal